I just wanted to start by telling Sana thank you for the invitation to come speak today. With that, we will begin by talking about what is new in the pharmacologic treatment of atrial fibrillation. So I'll begin by talking a little bit about one of the more famous atrial fibrillation patients that is out there, and I'm sure many of you will recognize Jerry West, who is not only a living icon figuratively, but also literally. It was his silhouette that was used to make the NBA icon, for the league. And I think that his story, specifically his perspectives on atrial fibrillation, is something that is very illustrative, I think, to folks who take care of this patient population. And I had the opportunity to hear him speak in person in Raleigh, and there is a YouTube video. This is not his speech in Raleigh, but it was one very similar, and I thought we would start with listening to that. That's how I would start. All right, so let's go back to this. I'll try to summarize what Jerry West. What?
Try it again.
Okay.
Thank you very much. It's really a pleasure for me to be here today. I get asked to do a lot of things, usually concerning sports, and I think this is a unique perspective for me to give you an idea of an athlete and someone who feels the symptoms of AFib, has had to deal with that for a number of years, and wasn't even diagnosed until I was 42 years of age. The tremendous toll it has taken on my body as AFib overcomes me, often when I least expect it. AFib robs me of quality time with my family and friends, and have made my career in professional sports so much more difficult. And that's what AFib does. It exhausts and overwhelms me, leaves me feeling as spent as I've played an NBA basketball game in a championship series where the adrenaline is just running out of your body. And as a professional athlete, I've experienced some pretty major and painful injuries. I've broken my nose 9 times. 2 players did it twice, by the way. I've had a major leg injury, which required surgery, tore a ligament. I tore the spring ligament in the bottom of my foot, had my hand broken twice and operated on twice. And I had a groin injury that really was the culmination of my career. And I will tell you, all these terrible injuries I've had, and nothing compares to AFib, at least in my mind. But the thing that I've been most surprised is at how many people that have this. And it's a hidden disease, there's no question. And I thought it was very, very interesting when I was a player that I would come in the locker room, and I had boundless energy, and I still have a lot of energy. And I would be, they'd give me a brown paper bag to breathe in because you're hyperventilating. And I'm saying to myself, well, hell, I'm not tired. I feel great, but I'm just hyperventilating. And as an athlete, you know your body so well. And I knew there was something going on. And finally, at age 42, I found out, not by an expert such as you people, but by a general practitioner. They didn't know how to deal with that. So little information. I want to thank you for the great work all of you are doing to care for, educate, and connect with AFib patients such as myself. I really do look forward to a productive day because I have tried to study this and try to understand it.
So I thought one of the things that was striking about Jerry West's commentary was number one, just the comparison to some of the injuries that he had underwent. He's obviously not a person who is a whiner or has a low threshold for pain or has trouble persevering through difficult situations. And he put all of the injuries that he encountered in his career and said the sum total of them was not as bad as trying to deal with atrial fibrillation. I thought that was striking. I thought likewise what was striking was when he talked specifically about how AFib, he felt robbed time from him and from his family. And I think that really highlights the quality of life impact with atrial fibrillation. And I think the other point that I took from listening to him was he also expressed a lot of frustration, and some of this was timing. And I think when he was 40 years old was a while ago, and we didn't know as much about AFib as we do now, and we didn't have the same kind of tools that we have available back then as we do now. But he expressed, I think, frustration that early in the process there was a lack of clarity regarding his diagnosis, a lack of explanation about prognosis, and very little, if nothing, short of the brown paper bag, offered in ways to treat the condition. And I think that was really something, talking to him after the session, that really came through, that he just really was frustrated with that. And I think one of the reasons he's been involved in this educational initiative is to try to, again, get the word out. He's really spent a lot of time talking to the healthcare providers, the people that take care of AFib patients, so that they are aware of, again, the impact this condition makes in people's lives. So that same evening, we also had a speech by another very good speaker, which many of you may recognize, Dr. Augustus Grant, who has been at Duke for many years, gave also a very nice talk, and he also emphasized the importance of treating atrial fibrillation and the impact atrial fibrillation had on people's quality of life. And I don't know if it was this study specifically that Dr. Grant cited, but I thought one of the things that caught my attention with his talk was that he referenced a study that looked at quality of life in AFib, but it didn't just compare it to normal controls. It compared it to controls with people who had a new diagnosis of myocardial infarction. And I think all of us knew, I knew as an intern walking into Duke Hospital about the concerns regarding post-MI depression and some of the impact that a new diagnosis of coronary disease and MI would make on people's lives. And in this study, they compared quality of life in patients with a new diagnosis of AFib to patients with a new diagnosis of MI, and strikingly found a quality of life score not as bad, but actually worse than the people with new diagnosis of MI. And I think thinking about how serious that diagnosis of coronary artery disease is, I think it begged the question, well, why is that? Why would the quality of life scores be lower with AFib than maybe with a new diagnosis of myocardial infarction? And I think Dr. Grant speculated on a cause which we don't have good data for, but speculated, said, perhaps one of the reasons is that we do maybe such a good job of dealing with people who have a new diagnosis of coronary disease that we deal with this problem in a very organized manner so that people come in with a new myocardial infarction. If you think about the infrastructure in place, people oftentimes have a diagnosis within minutes. People may be in the cath lab in less than an hour. People get new medications started that have an evidence-based approach. They get counseled on behavioral modification and hopefully get discharged with the ability to go to a cardiac rehabilitation program. They really get their problem addressed promptly. They get the information that they need to know about prognosis and treatment early and efficiently. And I think that's one of those things that in the Jerry West commentary he really felt was lacking. Again, some of which was timing, but as our tools improve for treating atrial fibrillation, then hopefully also we'll be able to make impacts on quality of life by improving the delivery of those tools. So what I was going to start here, just since the talk was on what's new in the pharmacologic treatment of AFib, I was going to try to put things in perspective in the sense of, well, what are the priorities? And everybody in the room who takes care of patients with AFib knows that there are a set of priorities, and I think in general, number one priority is appropriate anticoagulation, and this is usually the decision aspirin versus warfarin. and using decision tools such as a CHADS risk score to try to decide, who's at higher risk and where warfarin is indicated. I think the number 2 priority is making sure that there is adequate rate control, and that usually starts with beta blockers, but most people will have faster heart rates when they are in atrial fibrillation, and targeting resting heart rates of less than 80 beats per minute and activity with heart rates with moderate activity of less than 110 beats per minute have been fairly well established, and these medications help try to blunt those rapid rates that occur when atrial fibrillation occurs. And I think the number 3 priority is related to symptoms. So it's symptom assessment. Does the patient know when they're in atrial fibrillation or not? Does it make an impact on their life or not? And I think if it does, well, then you move on to the considerations of rhythm control and trying to reduce the burden of atrial arrhythmia. So I'll go to another basketball player that I encountered earlier in my training. This one a little bit less famous, but still made an impact on me. This picture up in the top left corner is Charles Mays. He was a basketball player and team captain at Vanderbilt University prior to pursuing medicine and becoming a chief resident at UT Southwestern prior to his cardiology training at Duke. And Dr. Mays was one of the first people that I encountered being a fresh intern at Duke. And I was in the CCU and I think a little bit disoriented. And one of the things I think that was troubling me is there were patients that we were caring for that were on medications that I wasn't quite as familiar with coming out of medical school. People on medications like flecainide and sotalol and amiodarone. It wasn't completely clear to me initially, who gets what medications and why. And so Charles came over to me and put his arm around me, and he could do that because even though I'm relatively tall, Charles was 6'8", and he could put his arm around whoever he liked. And he said, Hageland, it's all very simple. He said, the patients who don't have coronary disease, because coronary disease would contraindicate use of a class 1C agent, and have a normal ejection fraction, because again, an abnormal ejection fraction would contraindicate use of a 1C agent, those guys get flecainide. The folks who have coronary disease, which contraindicates the flecainide, but have a preserved ejection fraction, well, they can get sotalol. Sotalol has some beta-blocking effects which may help their coronary disease, and as long as their ejection fraction is normal, we don't have to be concerned about the increased mortality that was seen in trials such as SWORD. So that population got targeted towards sotalol, and he said everybody else gets amiodarone. And then he kind of walked about, and we continued in our CCU business. So we'll try to use that as our historical reference from the late 1990s, kind of one person's take on AFib pharmacologic management, and then talk a little bit about how it's changed over time. I try to organize the talk from this point forward in terms of sections related to the areas that we talked about in terms of priorities of taking care of AFib, starting with anticoagulation, then talking about rate control, and then talking about rhythm control. So I think the instrument that has been emphasized the most when trying to make the decision about what is the appropriate anticoagulation in AFib patients has been the CHADS-2 risk score. And I'm sure everybody in the room is familiar with this. There is some controversy about whether or not it's the best way to predict thromboembolic risk. But I think one of the emphases has been really on trying to standardize the approach of anticoagulation in this patient population. And if you have a tool that seems like it correlates well with risk, and it's one that's easy to remember, then it certainly seems like a good place to start. And as users of this tool will recall, you get 1 point for congestive heart failure, 1 point for hypertension, 1 point for age, realizing that age is a continuous variable, 1 point for diabetes, and then if there's any history of stroke or mini stroke or TIA in the past, then you get 2 points, and then you calculate your CHADS-2 risk score. And what you're trying to do when you're assessing thromboembolic risk is you're trying to say, well, is the risk of thromboembolism greater than the potential hemorrhagic risks associated with warfarin? Because the risk there likewise is not zero. And so as you see in the graph that's on the right, there is increasing thromboembolic risk with an increasing CHADS-2 risk score. And in general, when people have assessed this data, they have found that the risk of hemorrhagic complications with Coumadin in the general population may be in the neighborhood of 3%. So people who are CHADS-1 or only have 1 point will be in a little bit of a borderline area. But the people who have zero risk factors, they may have a lower risk of thromboembolism than they do of hemorrhagic complication with Coumadin. And the people who have 2 or more risk points will be at a greater thromboembolic risk than the hemorrhagic risks with Coumadin, and therefore should receive Coumadin. And so the 1 being in the gray zone, 2 and higher, Coumadin indicated, 0, Coumadin likely not indicated. And I think one of the things that we've seen, and this message continues to get driven home, and this is in a recent publication this year in the American Journal of Cardiology from Al Waldo's group, looked at registry data and looked at Coumadin use. And I think what they found here was, again, underutilization of Coumadin. And I think study after study after study has shown us that. And I think in general, care providers know why. They know that there are patients that have contraindications to Coumadin. They know that patients are out there that won't take Coumadin. They know there are people who have taken the medicine who have very difficult time controlling the INR values. There are many challenges, but nevertheless, I think people feel like there is room for improvement there. So one of the highlights of this article was talking about the underutilization of Coumadin. One of the other highlights of the article was about overutilization in people who had a relatively low risk. So I thought this was a nice example of, again, the importance of using the CHADS 2 risk scoring system. So here are people in the registry that underwent rhythm control, and here are people that underwent a rate control strategy. And you can see that the people who are CHADS 0 in both groups are getting Coumadin at a rate of around 40%. So again, people where the risk, the hemorrhagic risk with Coumadin may be greater than the thromboembolic risk, quite a few people are getting Coumadin. And if you look at the people who are CHADS 2 or greater, the treatment is only about 70%. So again, there's going to be people who have contraindications to Coumadin, but does that really account for 30% of our population? Can we be doing better here? I think the answer here is yes. And I think the point here is, well, again, with these people who are at very low risk, are we overutilizing Coumadin? Are we exposing these people to hemorrhagic risks when the risk of thromboembolic phenomena actually is quite low? Now, one thing I did want to highlight here is that these are chronic anticoagulation strategies, and as you will note from reading guidelines, there is a different set of anticoagulation guidelines associated with the time at which you are restoring rhythm, such as with an antiarrhythmic agent or with cardioversion, where that is a very high-risk time, and anticoagulation is clearly indicated in almost everybody for at least the 4 weeks or so after cardioversion. But in terms of a chronic strategy, the CHADS risk scoring seems to be a good system to use, and the people who are really CHADS 0 for a chronic strategy should be considered for aspirin-only therapy. People who have a risk score of 2 or higher should be treated with Coumadin unless contraindicated. So I think along those lines, again, some of the difficulty with underutilization of Coumadin has been related to the difficulties with this agent, difficulties from a patient and doctor standpoint. We all know how hard it is. We know that there are Coumadin clinics out there just made to deal, with the pain and agony that comes with using Coumadin. I think doctors and patients likewise have been looking forward to what is on the horizon, what is a medication that's going to make the pharmacologic impact to help replace Coumadin so that the thromboembolic events are prevented, but maybe in a more reproducible manner and maybe a less risky manner and hopefully a more effective manner. And there are a few agents out, and I won't talk about them in great deal.
Tom, before we talk about the new agents, if I may interrupt and ask you, could you point to us the several challenges that clinicians face in using Coumadin? I mean, you point out the underutilization of Coumadin, and this has been reported time and again. But I think it's, I think part of it is lack of knowledge, or maybe it's not on physicians' radar screen, if you will. But part of it also might be the challenges that physicians face when they use Coumadin. Could you point out some of these challenges, please?
No, I completely agree, Sana, and I think it's all of the above. And again, anybody who manages patients with Coumadin knows what a pain it can be. So I think there's initially, obviously, if you're not aware that Coumadin is indicated, or you're not able to assess the importance of Coumadin, obviously that's an initial problem. But I think the other barriers, I think I think there are a lot of patients who don't want to be on Coumadin. They're very concerned about having a problem with hemorrhage, whether that's related to a past experience or maybe they had a GI bleed, or whether it's a guy who rides a motorcycle or somebody who spent a lot of time working in their shop. There is a resistance there, worrying about hemorrhage that is serious and life-threatening. There are likewise concerns about risk related to things that are even cosmetic. A lot of people will talk about how much they bruise on Coumadin and they just don't want to be on those blood thinners. Likewise, the blood draws to check the INR has been an issue. The time spent in clinic is an issue. I think for physicians, I know one of the things that we do a lot in Durham, which may not be available everywhere, is the utilization of Coumadin clinics to try to make sure that INRs are followed adequately and the people's Coumadin doses are titrated appropriately. We all see patients in the clinic who have these crazy regimens that get generated in the Coumadin clinic about you take 2.5 milligrams this day and 5 milligrams that day. And we all know about the narrow therapeutic window with Coumadin, that if you have INR values that are less than 2, you're probably just wasting somebody's time. And if you have INR values that are substantially higher than 3, you're substantially increasing their risk of hemorrhage. And if you have somebody who has an adverse reaction related to one of these hemorrhagic events, it's a very powerful anecdote that's left in your mind. So I think all of these are substantial barriers, practical and consequential. So medications, again, that have come up on the horizon. Apixaban is a factor 10A inhibitor that is being studied. Rivaroxaban is a once-a-day factor 10A inhibitor that likewise is being studied, looking at, among many things, measures of reduction of thromboembolic risk in patients with AFib and looking for non-inferiority when being compared to Coumadin. And then we also have data that is available from dabigatran, which was discussed a little bit yesterday. Now it's a direct thrombin inhibitor, so a little bit different mechanism of action, but we have some data available looking again at how it compares compares to Coumadin in an AFib population. And I think again, at least this preliminary flow of information that's coming through is encouraging. I think maybe also just the fact that there are 3 medications that seem to be moving forward in this direction gives us hope that over the next few years we'll have a medication that will be easier to use than Coumadin, so that we can help ameliorate that thromboembolic risk and do so in a manner that is more convenient, as well as hopefully more effective in this patient population. So this is just a graphical analysis again of how the dabigatran compared to Coumadin. So you have the cumulative hazard ratio displayed here, the risk associated while taking warfarin, the reduction in risk seen with this non-inferiority trial with 110 milligrams of dabigatran, and then also with the higher dose 150 milligrams of dabigatran. And at least in this study, as with all blood thinner studies, people are very concerned about hemorrhagic complications. And what was important, I think, here, or encouraging here, is that not only was the agent found to be non-inferior from a thromboembolic risk standpoint, but in addition to that, it seemed to have hemorrhagic complication rates that, again, were comparable and maybe, if anything, just slightly lower than Coumadin, so trending in the right direction. So for a lot of the papers I'll discuss from this point forward, these aren't necessarily landmark practice-changing papers, but there are a lot of things that have come out in the past couple of years, and I thought since the topic was what's new in the pharmacologic management of AFib, I would try to focus on some of the studies that have come through that are important to this patient population over the past couple of years. So I did a very broad literature search looking at atrial fibrillation and crossed that with treatment and crossed that with pharmacologic drug or antiarrhythmic, and came up with some of these studies. I had quite a few studies initially, but tried to whittle them down to the ones that I thought were more interesting, again, for various reasons. I thought the study that was published in the New England Journal of Medicine was interesting from the standpoint that it talked about the benefit of adding Plavix to aspirin in people who could not take Coumadin. So for whatever reason, patients in this study could not take Coumadin, but they had Plavix added to their regimen. Their primary outcome was a composite endpoint that included stroke, but it was not stroke alone. And what they found, I think that made it interesting, was that there was an improvement in the primary outcome, and that the largest segment of the improvement actually seemed to be attributable to a reduction in stroke risk. So there was some reduction in stroke, and I think stroke is one of the feared complications of AFib. That can be obviously a life-threatening complication of atrial fibrillation, and if there is not the ability to reduce that risk with Coumadin, the ability to impact it with Plavix is, I think, of interest to a number of people, although it is important to note that the magnitude of reduction was not dramatic. It was less than 1%, and likewise, the hemorrhagic complications associated with use of Plavix also were higher. Again, less than 1%, but still not trivial. So the use of this agent for this purpose came at a cost. The primary outcome, again, which was the composite outcome in this study, compared again aspirin to clopidogrel, and they noted that the difference or the improvement that was seen with clopidogrel was accounted to a larger extent by the stroke outcome. So for patients, until other agents become available, and for patients who couldn't take Coumadin for some other reason, there is some evidence that Plavix may reduce the risk of stroke. I included this study as well. It looked at the race and ethnicity impact on quality of care. And Kevin Thomas is pictured in the top left corner, and he's one of our colleagues at Duke, and he wasn't involved with this study specifically, but he spends a lot of his time working on racial disparities. And I thought this study was one that really emphasized a point that I think he is interested in and believes passionately in, that it's important to look at the many reasons why there are inequities in patient care. And I think in this study they saw that patients who were black tended to receive anticoagulation and other evidence-based therapies at a lower rate than whites and Hispanics. And I thought, again, what was interesting about this publication is they said, well, with attempts at identifying the multifactorial contributors and many of the complexities leading to this, that the identification of these things led to improvement in quality of care. So I think that's really the goal of a lot of this research, is to try to, at the end of the day, improve care for patients. So we'll move on from anticoagulation on to priority number 2 for the treatment of AFib, and that really is rate control. And there was basically one publication that I came across which I thought was particularly interesting, and actually came out in the New England Journal just a couple months ago. And this study was titled Lenient versus Strict Rate Control in Patients with AFib. And what this study looked at was parameters that we talked about initially, kind of the standard strict rate control dogma, get everybody's heart rate down to less than 80 when they're sitting, then maybe walk them around in the office or put them on a treadmill and make sure their heart rate's not above 110 or the 110s with this relatively low-level activity, and compared that to a more lenient strategy where they said, well, we're just going to give you AV nodal blockers, we're going to give you medications to slow your rate in AFib, and we're just going to try to get it to less than 110 when you're resting, and we'll call it a day at that. And when they looked at this patient population, which is a little over 600 patients, they followed them for 2 years. The maximum follow-up was 3 years, so not a long period of time. And I think that's an important thing to try to keep in mind. But what they saw in this study was that people who had the more lenient strategy, or the maybe less invasive strategy, less aggressive strategy, actually had an improvement in their primary outcome. And the primary outcome was composite, but it was composite of a lot of important things: cardiovascular death, heart failure, hospitalization, stroke, systemic embolism, life-threatening arrhythmic event. So I think that the fact that there was a trend towards better numbers or better outcomes in patients who had the more lenient strategy was interesting. Likewise, they noted that people who had the more lenient strategy, as you would predict, had an easier time getting to their goal. They found that almost 98% of people were able to get to that resting heart rate less than 110, whereas only 67% of people were able to get to the more strict rate control guidelines. Likewise, again, as you would predict, they were able to achieve these goals with fewer clinic appointments. So it was easier to get there, more people got to target, and there was maybe a trend towards if anything, improvement, but at least if you did non-inferiority type of comparisons, you saw a favorable comparison with this strategy. Now again, I think you always have to take every bit of evidence-based medicine, even things that are published in the New England Journal, as with a grain of salt, and realize that if you're going to apply this data to your patient population, you need to see if the patients that were studied here, look like your patients. I think in general, looking at the people here, most of them were in their late 60s. I think in general they were relatively healthy people. 2/3 of them had NYHA classification as class 1. Only about 1 in 10 had any symptoms of heart failure or any hospitalization of heart failure. And only about 1 in 5 people even had a history of coronary disease. So again, it's maybe a relatively healthy patient, again, in their late 60s, maybe telling you that you may not have to be quite as aggressive with your rate control strategy, because sometimes, as we all know, when we're trying to rate control people, some of our rate control efforts come at a cost, particularly when you're piling one medication onto another and you're at maximum or supra-maximum doses of beta blockers and calcium channel blockers and adding digoxin, and people can't even hardly get off the couch. You start to wonder again whether you're helping those people or hurting those people, whether you're considering other invasive interventions, like saying, well, we can't get to where we need to go, so do we need to think about things like AV nodal ablation and pacemaker implantation? I think in general, for this patient population, it seemed that a more lenient strategy, at least over the short term, was reasonable. Whether or not this strategy applies to other patient populations is yet to be determined. Again, whether or not this strategy is something that would be a good idea in somebody who's younger, who's going to be living with atrial fibrillation and that more lenient rate control, not just for 2 or 3 years, but for 10 or 15 years, again, likewise, is an important issue.
So Don, you very nicely highlighted the limitations of this study. Going forward, since I agree with you, these results don't seem to apply to at least the general patient population that we see in our practice. Our patients are sicker, what have you. Do you think that this study needs to be repeated in a sicker patient population?
No, I think certainly. I think just in general, too, you think about how common atrial fibrillation is. We're talking about 600 patients. And so there's really, I think, again, that's why a lot of these studies are not necessarily practice changing. You shouldn't take the results of this study and apply it to everybody, in your patient group. But I think it's thought provocative, and I think what the point that Sana brings up is an excellent one. It really, I think, is a point that warrants further investigation, because it's one of actually key importance, and it's one that really shouldn't be terribly difficult to study. So I completely agree. I think that the jury is still out as to how applicable that strategy is for a broader patient population, and I think absolutely a trial would be useful to help answer that. So we'll move on to the final section, which is the kind of the third priority that we mentioned in our treatment priorities for atrial fibrillation, and that is one of rhythm control. And I know it's still relatively early in the morning, so I didn't want to spend too much time talking about action potentials. I wasn't sure if we had enough coffee for that, but I will just talk briefly about the action potential, and I think how some of the antiarrhythmics that we use impact the action potential, and the impact that it has helps predict maybe some of the things that we watch for clinically that are adverse outcomes related to these medications. So you have a standard action potential seen on the top of the slide, and you see the different phases of the action potential. And then on the bottom left side of the screen, you see the effect of class 1C antiarrhythmics, which tend to block sodium channels, examples which would include flecainide and propafenone. And the effect that blockade of the sodium channels, which play a key role in phase 0 of the action potential, rapid depolarization, you see that the slope of that rapid depolarization changes. So this slowed conduction that results in blockade of sodium channels will lead to things like QRS widening and PR prolongation. And then you could predict from those changes that you may run into trouble in certain patients with areas such as conduction block, or if you slow conduction enough, could you slow atrial flutter that you could actually conduct it 1-to-1? And that potential for 1-to-1 conduction of atrial flutter with agents such as flecainide is where the recommendation comes for always using an AV nodal blocker, with this agent. And you can predict, again, running into what troubles you're going to run into by looking at the channels that are blocked and what portion of the action potential is affected. Well, this is one antiarrhythmic mechanistic strategy to try to treat atrial fibrillation. Well, an alternative mechanistic strategy trying to address atrial fibrillation includes the use of class 3 antiarrhythmics. Agents like sotalol and dofetilide are potassium blocking agents, and they will tend to prolong the repolarization. Prolonged repolarization then will translate into prolonged periods of refractoriness. So maybe during atrial fibrillation, tissue when those wavelets are propagating through the left atrium and leading to the self-perpetuating AFib process, that may be prolongation of this repolarization and prolongation of refractory periods will lead to termination of the arrhythmia and allow people to spend more time in sinus rhythm. But this prolongation of repolarization is again going to come at a price. It is going to lead to the translation on the surface EKG is going to be QT prolongation. And if this QT prolongation is excessive, then there is going to be a risk of torsades de pointes, specifically with sotalol and dofetilide. So we'll try to regroup a little bit and go back to touch base again with the area where we reviewed earlier, where we talked about Charles Mays and his view back in the late 1990s about how antiarrhythmics were used for the pharmacologic treatment of atrial fibrillation, and compare it to something maybe a little bit more recent. This was a review article published on the management of atrial fibrillation, published in The Lancet in 2007. And I think what you'll see is there's actually a lot of similarities between this algorithm and the algorithm on the right. What you see when you're trying to figure out what antiarrhythmics are out there for given patient populations, you see people who have no structural heart disease, no coronary disease, normal EF people. They're class 1C antiarrhythmics, flecainide and propafenone at the top of the list. Of course, these people are candidates for other antiarrhythmics, and in some ways, these people, the world is kind of their oyster when it comes to antiarrhythmics. They can use about anything. So certainly class 1C agents are a good area to start. The folks who fall in this category will have many options. People who have coronary artery disease, those folks will have sotalol included in their list. People who have impaired LV function, agents like amiodarone likewise are there. I think one of the new agents that showed up that wasn't present in the late 1990s was dofetilide, and I think dofetilide is an agent that we end up using a lot of. Dofetilide has been around long enough now. There wasn't a high number of articles on dofetilide out when I did my search over the past couple of years, but this was one of them that came up, and it reminded me how much we tend to use this agent, that despite some of the difficulties with its use, it tends to be one of the more effective antiarrhythmics that we have available. It tends to be one of the antiarrhythmics that has one of the best side effect profiles. People usually don't feel much different on dofetilide than they do when they're taking a placebo, and there's not risk of cumulative side effects over time. So in patients who are younger, and you're going to be talking about prescribing dofetilide indefinitely, it has a very attractive risk profile. The downsides about using dofetilide is it is a little bit of a pain to get started. It is an FDA mandate that this medication be initiated in the hospital. You need to observe them for the first 5 doses. There have been issues in the past about being a TICASIN, which is the trade name of dofetilide, authorized provider, following electrolytes closely, following QT intervals 2 hours after every dose of the medication, and making sure that people's QT interval is appropriate for the initiation of the medication. Likewise, confirming that after initiation, the QT interval does not prolong by more than 15%, so not to put people at increased risk of life-threatening arrhythmias such as torsades. In this study, again, a relatively small study, but they were looking specifically at the problem of post-operative atrial fibrillation. They were able to show that dofetilide was effective in this population, reducing the risk of post-op atrial fibrillation from 36%, cutting it in half to 18%. In our practice, we tend not to use dofetilide very often in this patient population because, again, it's cleared by the kidneys, and you'd like to have nice, stable renal function when you're using it. And a lot of times people after big surgeries like coronary artery bypass grafting surgery may not have stable renal function, and starting the medication and stopping the medication would likewise only complicate their hospitalization. In this patient population, we tend to use amiodarone most frequently. The reason being it's relatively easy to administer. It is a very effective antiarrhythmic, and if you're talking about using it just for the purpose of suppressing a reversible cause of the arrhythmia, such as a post-operative setting, and then maybe discontinuing it 6 weeks down the road, I think the likelihood of having significant risk associated with a 6-week exposure to amiodarone is going to be quite low. And so for this particular area, we really tend to use amio more, but I thought it provided an opportunity to talk a little about dofetilide, which I think is, again, a very useful agent in this population. I included this abstract as well because it just mentioned the agent vernaculant, which blocks multiple different ion channels, but is thought to be relatively atrial selective, and is being tested in this country for its ability to convert acutely atrial fibrillation into sinus rhythm via IV administration. And in this study published earlier this year, they were able to show that there was some important effect of vernaculant when administered, again, alone as an IV conversion agent. People who had atrial fibrillation for less than 7 days converted 51% of the time with the vernaculant alone. People who had AFib for longer periods of time did not have as much success. People who had it for 7 to 45 days only had a conversion rate with the pharmacologic agent alone of around 12%. I think in general there's a lot of variation in practice patterns of use of these pharmacologic cardioversion type agents. Ibutylide is another one that we will use from time to time. I think in general our use of these agents has been relatively minimal. We tend to use direct current cardioversion more frequently than pharmacologic cardioversion. However, sometimes in the EP lab, and then sometimes also maybe for that difficult person where maybe direct current cardioversion could use some assistance with a pharmacologic agent. The IV agents can be helpful. Likewise, maybe if there are issues regarding anesthesia coverage where having a pharmacologic agent is more attractive, then there may be another one to choose from in addition to ibutylide with the emergence of vernaculant. The next study I was going to talk about just briefly was a study that was published in JAMA. I thought this was, again, somewhat interesting, a recent study looking at a medication that's been around a long time, looking at amiodarone and using it with different treatment strategies, either using it as a continuous agent, so once you restore sinus rhythm, just continuing the amiodarone indefinitely, or after a month, if you're still in sinus rhythm, stop the amiodarone at that point and then see if you need it again. And I think the thing that was interesting here, in terms of their primary outcome, there really wasn't much of a difference. But in terms of secondary outcome, which included the need for repeat hospitalization and mixed mortality along with that, there were trends towards improvement with the continuous for use of amiodarone. So maybe a point being argued by this paper is that if somebody doesn't have a reversible cause, such as somebody in the post-operative setting, or somebody that has AFib in the setting of hyperthyroidism, or some other cause that you're going to fix, then the likelihood that you're going to have recurrences of AFib are going to be relatively high. And if you discontinue the antiarrhythmic, in this case amiodarone, then it's not going to be surprising when they come back with more AFib, maybe require additional antiarrhythmic loads, maybe additional cardioversions, and that maybe some of those additional procedures may be associated with additional risk. This study, I thought, again, was interesting. There was just a piece of it that I found interesting. These were patients that actually had Tachy-Brady syndrome and had pacemakers implanted for the purposes of Tachy-Brady syndrome. And again, folks who take care of the sick sinus population and the Tachy-Brady syndrome that oftentimes overlaps with the paroxysmal atrial fibrillation people know that pacemakers can be very useful in this setting, and know that there may have been attempts at pharmacologic treatment that failed prior to you putting in the pacemaker. The people in this study actually had a pacemaker capable of anti-tachycardia pacing in the atrium, which I think in general is not something we use frequently. I don't think we find that it's terribly effective, and I think we do find that it tends to drive patients crazy. So it's not a therapeutic modality that we use very often. But what they saw in this study was that people who received their pacemaker and then were treated with sotalol versus people who received a pacemaker and were treated with beta blockers had fairly similar outcomes. And I think, again, with any antiarrhythmic, no matter how good the safety profile is, there's usually some increased risk associated with the antiarrhythmic properties. And under those circumstances, if you could get away with using beta blockers only, then that in general probably would be a good thing. So I think because there is a little bit of an overlap with the AFib population and the folks who have more of a Tachy-Brady sick sinus syndrome, the concept of saying, well, if we're going to put in a pacemaker and do something a little bit different, if we're going to be able to use beta blockers in a way we weren't able to use before, maybe it might be worthwhile using those beta blockers and getting people on a good dose of them and seeing how they do. The pacemaker will give you beautiful information about whether or not they are having recurrent atrial arrhythmias, how long those episodes are lasting, how fast their heart rate is when they recur. We always get great data on the AFib patients when a pacemaker is in place. So if you need to start an antiarrhythmic after having the pacemaker there, then you certainly will have all the data you need to do so. This study I just included because it mentioned the concept that omega-3 polyunsaturated fatty acids may have a positive impact in reduction of future AFib events. And again, I think this is a concept that is out there, and there are believers and disbelievers, and we'll have to see where the data takes us in the future. I think likewise, thinking about pharmacologic management of AFib and kind of what's new and where's the new data, there's data in addition to use of antiarrhythmics using agents that are not specifically antiarrhythmics. And I thought this was a nice study, a systematic review looking at the effect of statin therapy for the prevention of recurrent atrial fibrillation, and again finding a lower likelihood of recurrent AFib in people who are taking statins, looking at a little over 3,000 patients in this population. And when they were able to graph the summary of their results, finding a composite or a final summary risk reduction associated with statin and recurrent episodes of atrial fibrillation. I think likewise, again, the meta-analysis or systematic reviews can be very powerful tools looking at large numbers of patients. And earlier this year, meta-analysis was published in the Journal of the American College of Cardiology, looking at patients who had blockade of their renin-angiotensin system. And if you followed the literature on this area of interest, the data has been scattered. One study will show benefit, one study won't show benefit. Again, providing an opportunity over time to help pool that data in the form of a meta-analysis and try to decide whether or not it seems like there actually is benefit with blockade of the renin-angiotensin system in this population. So here, again, the number of patients that were included in this meta-analysis were over 80,000 patients, a large number of people. And the finding here, although there was a caveat of some heterogeneity between studies, was that there tended to be a reduction in the relative risk of atrial fibrillation with the use of renin-angiotensin system blockade. And I think listening to Dr. Alexander's talk yesterday and talking about maybe some of the ways we do such a good job with coronary artery disease and acute coronary syndrome management in the hospital. Dr. Alexander was talking about his little card that he keeps to remind himself about the evidence-based therapies for people with coronary artery disease and acute coronary syndromes. Is this patient on an aspirin and a beta blocker and a statin and clopidogrel and an angiotensin receptor blocker, going through that list so that he isn't missing people, so that there aren't people who are falling through the cracks, so that he has people on the best pharmacologic regimen for treatment of their disease condition. And I think, again, maybe some of this data may be pointing us in the direction that there may be a similar approach applicable to patients with atrial fibrillation. Is the person on the appropriate anticoagulation for AFib? Is the person on the appropriate rate controlling agent for AFib? Is the person on additional agents that can help reduce the amount of AFib they may experience in the future? And does that list include, beyond antiarrhythmics, other agents such as statins and renin-angiotensin system blockers? I think that there's a lot of parallels between the two approaches. And again, this is just a summary of the data in the meta-analysis showing results favoring the use of blockade of the renin-angiotensin system. Another article that I came across that I thought was good talked just about milrinone. Obviously, one of the better ways to try to treat something is to keep it from happening in the first place. And anybody who sees inpatient consults in the area of cardiology will a lot of times get called for patients who have postoperative atrial fibrillation. And I thought this study published in Circulation a couple years back looked at people, they stratified people who had mitral valve surgery and people who had no non-mitral valve surgery, and then looked at people who received milrinone versus no milrinone in each group, and looked at the number of folks who developed atrial fibrillation and folks who did not develop atrial fibrillation, and again seeming to find a correlation with the use of milrinone in the post-operative setting. So again, the idea of prevention is out there. If you can try to avoid the problem, that's even better than having a great medication to treat it. The final medication I'll talk about is one of the newer antiarrhythmics that we have available, and that is dronedarone, or trade name Multac. And this was a recently published commentary in the Journal of the American College of Cardiology, which I think had substantial input from the FDA as well, talking about dronedarone and asking again about what is the role of this agent in the management of atrial fibrillation. And dronedarone certainly has been a well-studied agent. It has been through a number of randomized controlled trials with a large number of patients looking at various outpoints over time. And I think that what you can say from this data is that dronedarone is an effective agent. It does work better than placebo for reducing the amount of AFib that is out there. However, it does so to a very modest degree. And I think the relatively modest antiarrhythmic effect of dronedarone needs to be taken into account when you think about selecting an antiarrhythmic for a patient. Likewise, especially when you're putting it into the whole patient portfolio, which includes the higher cost associated with newer medications, as well as potential concerns about risk. So some of the earlier studies compared dronedarone to placebo, looking for the treatment of atrial fibrillation and looking at times to recurrence. There likewise were studies looking specifically about the ability of dronedarone to act maybe not as a rhythm controlling agent, but as a rate controlling agent. Most people, if you've seen folks who get things like amiodarone, you see that the rate in AFib is slower even if the rhythm is not improved. So they tested the ability of it to act as a rate control agent, and kind of a similar story, it works. It is better than placebo, but the effects, again, are relatively modest. They went a step further, saying, well, maybe we should also look in patients with heart failure. AFib is a big problem in people with heart failure. Maybe we should look at people with advanced heart failure. And there they found news that they didn't want to find, that people with more advanced heart failure symptoms or recent heart failure exacerbations actually had trends towards increase in mortality that generated a black box warning with this drug when it came out. So dronedarone is not to be used in patients who have significant congestive heart failure symptoms or reduced left ventricular ejection fractions. And that obviously was a big disappointment, because I think when people started working on dronedarone, people said, we're going to try to take amiodarone, one of the most effective medications, antiarrhythmic medications we have available, one of those medications that has this safety profile. For a while, it was the only medication that seemed to be safe in people who had congestive heart failure, and we're going to cut off the iodine, the moieties, and modify the molecule so that we get all the good things, all the good antiarrhythmic effects, but we're not going to get any of the bad. And although that was a great idea, I think the translation ended up to be a little bit less than what people hoped. And clearly in the heart failure population, this proved to be an agent that had potential risk. Likewise, this agent was also studied in people with a direct comparison to amiodarone. So just from an antiarrhythmic effectiveness standpoint, what if we use the standard dose of amio that we use in AFib patients, 200 milligrams a day, and we look at dronedarone and what's the efficacy outpoint? And it was very clearly demonstrated to be inferior. So dronedarone is not as good of an antiarrhythmic as amio. It has safety concerns and risk in patient populations where amio does not. And I think again, that does not mean this is not an agent that should be used or should be considered in patient populations, but those concerns should be thought of. And
so, Don, if we look at the data on antiarrhythmic medications, we see that until the data on dronedarone came out, not a single antiarrhythmic medication has been proven to improve survival and improve like really hard endpoints. And yet when we look at the trials looking at dronedarone, clearly there are some favorable results in that regard. Do you think then that since it doesn't look like the effect on these hard endpoints is mostly mediated through its effect on atrial fibrillation, that maybe dronedarone has some other mechanisms by which it may improve those hard endpoints?
And it certainly may, and one could speculate that, almost that it must, that, you have a hard time explaining the improvements that have been seen with the antiarrhythmic effect alone. This article, I don't know if you read this specific article, was really pretty harsh on dronedarone, and again, I'm not sure how much of this came from the FDA specifically. There were actually some concerns expressed about some of the validity data in the trial that Salman's referring to, Athena, where they seem to have improvement in these hard outcomes, because initially those values actually were not statistically significant, and they enrolled a few more hundred people, and then they became statistically significant. And I think that there were some concerns about that data. I think one of the things the study does, and I'll show it on the next slide, is it says, well, if again those kind of hard endpoints are what we're really interested in with this medication, well, again, we've got more patients than just the Athena population that were studied, and if there is this survival benefit, if you give patients this medication and more of them end up alive at the end of the day, maybe we should see that again in using almost kind of a meta-analysis sort of review. So I'll pull that one up next. I'll just show you here again, just in terms of putting numbers. Okay, I'm sorry. I'm putting numbers on the amount of reduction. So again, with control populations, timed a recurrence rate of atrial fibrillation from 47% down to 37%, again about a 10% decrease. Looking at the improvement in rate control with this agent, again, actually maybe that's not on here. So, and then in terms of its comparison to amiodarone, again, amiodarone being actually more effective, having a lower recurrence rate than dronedarone. And again, this is the data showing, again, it's an effective antiarrhythmic. It just tends to have a modest effect. This is the pooled data that I talked about, where they pooled all of the patients studied with dronedarone to try to see was there an all-cause mortality and or cardiovascular hospitalizations benefit. And again, we saw risk ratios that overlaid Unity. Likewise, all-cause mortality numbers again that were overlapping Unity. So if you look at all the patients that were studied, there doesn't necessarily seem to be that improvement that was seen again just with Athena alone. And so they proposed a algorithm, again, that has a lot in common with some of the previous ones that we put forward. I think it, again, tries to put dronedarone in the places where they felt like it was appropriate for consideration. And I wanted to highlight here, again, some of the other concerns. These algorithms are nice to say, well, I should think about this medication and this patient population, but realizing that there are other issues at play, that issues such as creatinine clearance and QT interval are of critical importance with dofetilide and sotalol because they're eliminated by the kidney. People with significant renal insufficiency are not going to be good candidates for these agents. Cost and hospitalization, needing to start dofetilide as an inpatient, concerns about intolerance of the beta-blocking aspect of the medication with either sotalol, amio, or propafenone, concerns about comorbid lung, liver, thyroid disease, cumulative effects with age, notation of effects on Coumadin and digoxin dosing with amio, sinus node function, knowing that if you give somebody agents like sotalol, dronedarone, amio, propafenone, if they already have sinus node dysfunction to begin with, they're going to have more of it with this agent. They may have more AV conduction delay, again, with class 1C antiarrhythmic agents. The risk of heart block, again, may be higher and may be of concern in patients who are older and at higher risk for AV conduction system disease. Remembering that class 1C agents in your patients with pacemakers will increase their pacing threshold, which may be particularly important in people who are pacemaker dependent. Any previous adverse reactions, any issues with heart failure, which a lot of times contraindicate these agents, and then notation of patients who have defibrillators, that medications like amiodarone may increase the defibrillation threshold, and that is something that needs to be kept in mind, and that effects of agents like dronedarone on defibrillation threshold are unknown. So what I was just going to say as kind of my last slide, hopefully has a little bit of a segue to Dr. Ornitsky's talk. I think one of the other things in terms of what's new about the pharmacologic treatment of atrial fibrillation is that the combination of antiarrhythmic drugs that didn't work in the past oftentimes find themselves working and have a lot to add in patients who undergo AFib ablation. And this was a systematic review that was published in Heart Rhythm looking at people with persistent AFib. So some of the really tougher people to deal with, people who are in AFib all the time and failing medications, and seeing that the success rates with a single procedure compared to the success rates with the procedure combined with an antiarrhythmic drug, you see the amount that pharmacologic therapy may add to this intervention. This is just a slide with the guidelines for reference, and final thanks.